Good morning, good afternoon, and welcome everyone to today's webinar, Chaplaincy and Mental Health, Empowering Chaplains for Integration with Rachel Daly. I'm Andrew Andresco with Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of that same control panel. You may send in your questions at any time. We will collect these and hope to have them during a brief Q&A session at the end of today's presentation. I did want to bring your attention to an upcoming webinar we have on Wednesday, February 28th at 2 p.m. Eastern, Research and Practical Tips for Palliative Care Clinicians Attending to the Existential Experience. You can register for this webinar at our website, www.transformchaplaincy.org. We'll also put a registration link into the chat box towards the end of the webinar. Rachel did upload a handout with resources. That's located in the control panel. You can download that. I will also put the URL link into the chat if you're having difficulty seeing that or downloading that. And with that, I'd like to introduce Rachel Daly, Spiritual Care Coordinator with Ascension.
Thank you, Andy. Oops, there we go. Yep. Perfect, okay. Looks like the slides are up and running. Welcome, I'm delighted to be with all of you today, sharing on this topic, chaplaincy and mental health, empowering chaplains for integration. This is the final part of a three-part series on mental health and chaplaincy. The first two parts of this series examined the principles of evidence-based care. In part one, my colleague Kirsten Almos and I looked at the research evidence about what we know about spirituality and mental health treatment. And then in part two, Kirsten explored how we can apply that evidence through our clinical encounters, using and building on our chaplaincy skills to provide effective spiritual care support in the context of mental illness. Now, I'll be referring back to parts 1 and 2 today, and you can access those recordings through the Transforming Chaplaincy YouTube channel. Today with part 3, we will move to applying these principles on an organizational level. So moving from our individual clinical encounters and thinking about the institutions and contexts where we are providing our chaplaincy care. We'll consider how we can develop chaplain competence to empower ourselves and our colleagues to integrate spiritual care and mental health. Throughout this series, we have been working with the following definition. Chaplaincy refers to the work of clinicians who have specialized training in spiritual care and work for an institution in either a paid or volunteer capacity as a chaplain. Mental health is a very broad term that refers to many different conditions and experiences. And within this series, we're using mental health to refer primarily to difficulties people experience with mental illness and substance use, and I'll be using this term interchangeably with behavioral health. As we begin, I would like to ground what I will share today in 3 key values, which reflect some of our shared values within the profession of chaplaincy. A first value is equity, and in the context of mental health, this means that how we care for and respond to mental health needs should be equitable with how we offer care for other kinds of concerns. So that within our available resources, we seek to provide support for mental health that is comparable or commensurate with the care we offer elsewhere, and that our spiritual care response reflects the same skillful, compassionate presence that we would offer in response to any other health or life problem. Equity means that we could look at our behavioral health units or areas and see a comparable level of chaplain presence, intention, and integration, of course, relative to volume, acuity, and many other factors, as we would see in other units and areas. A second key value is integration. And today I'll be speaking specifically about the integration of spiritual care and mental health. And this integration goes both ways, integrating spiritual care with mental health and also integrating mental health as part of spiritual care practice. I understand integration as intentionally and proactively addressing spiritual and mental health needs, so that our spiritual care practice is intentionally and proactively responding to mental health concerns, and that mental health care is intentionally and proactively responding to spiritual needs. This third value of empowerment reflects that chaplains already have many of the resources and strengths to work effectively in spiritual care, including in mental health. While there is some uniqueness to mental health, we can build on the skills and values that are already part of our professional practice, and we can engage the strengths of our chaplain formation. So throughout this presentation, I'll be sharing some ideas and frameworks for how we can express these values through our work. I will introduce a three-tiered empowerment model that offers a framework to think about the skills and competence that can empower chaplains to work effectively in mental health in different settings. And we'll explore how we can develop our competence and address potential gaps in chaplain knowledge and experience. And to make all of this a bit more concrete, we'll also look at a case example as a way to illustrate what some of these values might look like in practice. Now, as I introduce these values, I expect that some of us might experience a degree of dissonance between the seemingly lofty goals of equity, integration, and empowerment, and the realities and challenges of the settings and the contexts where we practice spiritual care. So I want to acknowledge some of these challenges around the integration of chaplaincy and mental health. One challenge we may encounter is that religion and spirituality have historically not been integrated in mental health treatment. And we saw in our literature review in part 1, significant unmet spiritual need in mental health treatment, despite a lot of evidence that this is an important component of care. So as chaplains, we work within and are associated with the domains of religion and spirituality that often have not received a lot of emphasis in mental health treatment, and sometimes have even been regarded with mistrust or suspicion. In addition to these barriers around religion and spirituality more generally, we may also encounter questions related to the role of the chaplain in particular. In mental health, as in many other settings, our colleagues sometimes have inaccurate or incomplete understandings of the chaplain role, and we might encounter barriers related to trust, buy-in, or support for chaplains and chaplain involvement in mental health. We might also experience barriers related to chaplain education and the resources that we need to be able to do our work effectively. While mental health struggles are very prevalent, we did see in part 1 that mental health topics are not consistently addressed in chaplain education and training. And as a result, chaplains don't always feel well equipped to address mental health concerns and may not have readily available tools to develop that knowledge. In addition, our chaplain resources are often limited. Oftentimes, chaplains are managing competing demands on our time, and that limits our ability to proactively meet all of the spiritual and mental health needs that are present in our setting. We might also have questions about how chaplains can collaborate in addressing spiritual and mental health needs, or what chaplain integration looks like in our setting. And we may encounter a lack of established models or frameworks to help us answer those questions. A final barrier I'll mention is stigma and bias. Mental health challenges are often stigmatized, and we as chaplains are not immune from that very pervasive stigma. Stigma can impact our spiritual care teams and institutions and the way that support and resources are provided within behavioral health. Now, as we look at these barriers, these reflect structural and systemic challenges. These kinds of barriers require us to look beyond our individual clinical encounters and to think critically about the systems of care that we interact with. So I want to emphasize the importance of critically and thoughtfully engaging with the broader systems, cultures, institutions, and contexts that we are part of. Just as our chaplain care is formed by careful and ongoing assessment, the way that we respond to these systemic barriers requires a similar process of assessment. And if our goal is to integrate spiritual care and mental health, we have to think carefully about both sides of that equation, what both spiritual care and mental health look like within our institutions. So we're going to talk a little bit about context and why assessing our context is so critical to the goal of integration. So in thinking about context, I first want to articulate why context is so critically important and why I think context is particularly important when it comes to mental health. One reason that context is important is due to the nature of mental illness. Mental illnesses are health conditions that impact thoughts, feelings, and behaviors. And our thoughts, feelings, and behaviors are influenced by many different individual, family, and cultural factors. And all of these factors are relevant considerations to how mental illness is expressed and treated in a particular person. And to illustrate this, I share an ecological model for mental health. This comes from the University of Minnesota. And this image shows a series of concentric circles, starting with individual factors in the most interior circle and expanding through the domains of relationships, organizations, communities, policy, and society. And this model reflects that each of these levels is relevant to mental health and well-being. As spiritual care providers, we support people as they make meaning across these diverse, layered, and specific contexts. So we think about who our care recipients are. What are the different systems and cultures that our care recipients interact with? And how can our spiritual care respond to the unique demographics and contexts of the people we care for? A second reason why I emphasize context is due to the nature of mental health treatment. Often in healthcare, the care environment is somewhat incidental. The care environment is there to facilitate the delivery of tests and procedures and interventions. However, in mental health treatment, the interventional tools we use are often people and relationships, and the therapeutic environment is itself part of the treatment. This is what is often known as the therapeutic milieu, which is the idea of maintaining a safe and structured environment that is rich in meaningful and supportive interactions that facilitate healing and healthy behaviors. So to provide spiritual care effectively, we need to be attentive to the nuances and dynamics of the particular care environment because they are an important component of the treatment itself. And we might consider that we are also part of the treatment context. When we step onto a mental health unit or facility, we are also part of that treatment environment. And so we can attend to our own contexts, our self-awareness, and the personal and professional experiences and frameworks that we bring and contribute to that therapeutic environment. So as we think about the many factors that impact us, our care seekers, and the care environment, what are some of the factors we would want to assess and be sensitive to that are relevant to how we go about integrating spiritual care and mental health? So I'll highlight some of the things we would want to consider in thinking about our contexts and how those contexts shape the care that we provide. So in terms of behavioral health context, what are some of the factors that we would want to consider and assess? One is patient characteristics and clinical needs. So who are the patients we are caring for? What are some of the psychosocial factors that impact care recipients? And what cultures or specialty populations are represented? What kind of symptoms and diagnoses are care recipients impacted by? What is the level of acuity in our care setting? Are care recipients acutely ill or somewhat more stabilized? We also want to think about the care setting. What clinical and support services are offered and how? What is the treatment framework? What do we understand about how people get better in this environment? And what is expected of care recipients? What disciplines are involved in providing care? And if care is provided in groups, what are the norms and expectations surrounding those groups? Finally, we want to consider a variety of factors under this umbrella of care environment and organizational culture. And by this, I mean everything that supports and surrounds the care we provide in terms of the physical environment, the day-to-day functioning of a unit or facility, how team members interact and communicate with one another, what kinds of stressors are present in the environment, and how those impact morale. Just one example of this is that some care environments are very specialized in caring for persons with a particular illness or symptom. And some care settings have a very heterogeneous population and support people with many different kinds of diagnoses. And each of these requires a very different response. In addition to assessing behavioral health, mental health contexts, we also want to assess our spiritual care contexts, as well as our own personal context, as this is part of what we are seeking to integrate. One obvious consideration is chaplain coverage and the availability of chaplain resources to meet the spiritual needs that are present on behavioral health units and areas. These considerations include how chaplain resources are allocated and utilized, and whether or not comparable or equitable levels of support are offered on behavioral health areas relative to other care areas. We can assess not only the availability of chaplains to provide care, we can also look at the skills and the resources and the competence that is present to provide that care. What resources are available around education, professional development and supervision. And we can also look at ourselves as part of the context to see what values and attitudes we hold and what is sustainable for us. Another consideration is the perception of spiritual care, how the chaplain role is viewed, valued, and understood. What is the degree of buy-in from leaders, and what are the attitudes of frontline staff towards spiritual care involvement? Sometimes chaplains encounter reservations about our involvement in mental health treatment. However, sometimes chaplains are held in such high regard that our colleagues want to protect us from the potentially inappropriate behaviors that patients might exhibit. And both of these situations reflect a need to build trust. So to make this process of context assessment a little more concrete, I want to bring in a case example and introduce a particular hospital. This is Ascension St. Mary, Chicago, where I worked in the spiritual care department as the team lead before coming to my current role at the Ascension Housing and Health Alliance. And we'll take a look at this particular setting to better understand and apply this process of context assessment. So this is a community hospital on the near west side of Chicago. This hospital serves a significant inpatient behavioral health population and is also a safety net hospital with significant comorbidity of medical and behavioral health problems across all care areas. Our spiritual care department had traditionally supported inpatient behavioral health by assigning one dedicated chaplain to provide care on these units. However, over time, this model of one dedicated behavioral health chaplain had grown increasingly inadequate to address the existing need. We saw a shift in inpatient volumes toward behavioral health, such that about half of our patients were primarily seeking care primarily for a medical problem, and half primarily for a behavioral health problem. In looking at this particular context, I want to highlight a few key observations and themes that emerged that were relevant to the integration of spiritual care and mental health. One observation was an unequal use of chaplain resources. While patient volumes were pretty evenly split between medical and behavioral units, a much smaller proportion of chaplain resources were dedicated to behavioral health. And this created an imbalance in how we provided care, with patients and associates on behavioral health units receiving less chaplain support and less consistent chaplain presence. Another observation was related to chaplain values and skills. This was important because mental health needs were present across every area of the hospital, not only on the behavioral health unit supported by the behavioral health chaplain. And chaplains approached this care with very different values and different levels of understanding of mental illness and its impacts. A third observation was that there was some complexity to the care that was needed on the dedicated behavioral health units. Generally speaking, patients were acutely ill, so there were always safety concerns about any items or materials we might bring onto the unit. And the environment could at times be disruptive due to the severity of illness symptoms that were present. Units and groups were heterogeneous with a variety of different diagnoses that could potentially be present, which meant chaplains were responding to many different kinds of needs and symptoms at the same time. There was also uniqueness to each of the different behavioral health units, and in particular, a difference in culture between the adult and the pediatric units. So this again required flexibility and the ability to adapt how we approach spiritual care across these different areas. A final observation from this context is a phenomenon known as associative stigma. And associative stigma is an extension of the stigma experienced by people living with mental illness, because often family members of someone with a mental illness, as well as caregivers and mental health care workers, also experience stigma due to their association with mental illness. And associative stigma played out in this context both directly and indirectly. Sometimes healthcare workers and mental health received less recognition and support, and were even exposed at times to negative attitudes from other healthcare colleagues. So this associative stigma created some additional challenges in terms of the emotional and spiritual well-being and the morale of behavioral health staff. I'll return to this example a little later on. For now, this illustrates how we might think through some of the dynamics and specific considerations that might be present within a particular context. So having looked at why context is important and considers some of the contextual factors that are relevant to how we would go about integrating spiritual care and mental health. What would we then do with this information, having collected this data and identified some key observations about our settings? So here I want to return to the theme of empowerment and introduce an empowerment model that I developed that describes 3 levels of chaplain competence. Each level builds on our skills and areas of expertise in order to support the different levels of complexity that we might encounter in our work. This empowerment model includes 3 levels: informed, practitioner, and leader. Today, I will be applying this empowerment model in the context of mental or behavioral health, but it should be noted that this model could be applied to other specialty areas within chaplaincy. So applying this empowerment model within behavioral health, this gives us a way to conceptualize the different types of competence that chaplains might need to meet the spiritual and mental health needs of our settings. So I'll go on to describe each of these 3 levels. I'll explain why each is important and explore some key areas of skill and competence at each level. And I'll share how I applied this framework to support more effective spiritual care integration in the case example that we've been looking at. And I'll suggest some different educational strategies to support developing our competence at each level. So first, we'll look at this foundational level of the empowerment model. This is the behavioral health informed chaplain. And this level reflects that every chaplain needs a basic understanding and competence in responding to mental health needs. Mental illness is very common, and it's particularly common in the kinds of environments where chaplains work, because we typically work with people who are impacted by some significant health or life stress. And as we saw in part 1 of this series, every chaplain in every setting is routinely responding to mental health concerns. And this is why it's important that all of us have some basic competence around mental health. So what is it that chaplains need to know, need to value, and need to be able to do to address this behavioral health component of care? So we'll look at this competence in terms of knowledge, values, and skills that can empower us in providing effective spiritual care support. In terms of knowledge, one of the foundational pieces of knowledge is to understand that mental illnesses are health conditions. This means that mental illness is not a personal, moral, or spiritual failing. As a health condition, mental illness requires treatment and can't always be resolved through spiritual interventions alone. It's also important that we have some working knowledge of key concepts like depression, trauma, suicidality, and addiction. These experiences are very common, and they're likely going to be present in any care setting where we're working. However, this list is not exhaustive. Within your particular environment, there might be other clinical factors that chaplains are encountering routinely and need to have some basic understanding of. All chaplains can have an understanding of the major role of stigma in mental health and its treatment, because I don't think we can really understand or empathize what it's like to live with a mental illness without looking at stigma. Stigma impacts not only patients, but also our colleagues who often face our own mental health challenges. And as I shared earlier with associative stigma, stigma can also lead mental health care workers to be viewed negatively. So this is something that impacts our care recipients, our institutions, and our own attitudes and experiences. It is important for us to understand. In terms of values, some of the values that chaplains embody include unconditional positive regard and upholding the dignity of all people. Of course, these are not new concepts, but they are particularly important when it comes to mental health. Mental illness can be very distressing, first and most importantly for the person being impacted, and also for people who witness that distress. So one of our first tasks is to manage and contain our own anxiety so that we can offer a relatively safe space for someone's story to unfold. Even where we don't understand all the complexity of mental illness, we can show empathy, offer non-judgmental listening, and communicate respect. And this posture, these values of acceptance and warmth, can bring some healing from the shame and isolation that all too often accompany the experience of living with mental illness. Another value I emphasize is providing trauma-informed care. Again, this is likely a familiar concept, and I emphasize trauma-informed care, trauma-informed perspectives, because it offers another pathway to being present in a more compassionate way. The behaviors that we observe in mental health are often someone's survival strategy for coping with traumatic or chaotic life events. And these principles support humility and non-judgmental presence because we often don't know what someone has gone through that has led to the behaviors or the coping strategies that we observe. In terms of skills, all chaplains provide support for persons with either a history of mental health needs or an acute mental health problem. And in part 2 of this series, Kirsten shared some wonderful examples of what this care and support can look like. Another area of competence is promoting the safety of patients, associates, and the environment. In healthcare settings, safety is always an area of focus, and it's something we all contribute to. I remember that early in my CPE journey, I encountered a patient who reported to me experiencing some suicidality. And this was not on a behavioral health unit, this was on a general medical unit. And at that time, I did not know how to respond or what actions were appropriate to take. And this can obviously create a safety concern. So we all need to have some understanding around how to support and promote safety. A final skill that we can all practice is using respectful, non-stigmatizing language. This includes person-centered language or language that emphasizes the person rather than the diagnosis. It also means being thoughtful in the words we use and what those words represent for the people around us. And this is just as true in our patient-facing activities as it is in our interactions with our interdisciplinary and spiritual care colleagues. Now, returning to this case example, I'll highlight a number of steps that we were able to take toward cultivating chaplain competence at this basic informed level. And these steps speak to normalizing mental health as a routine and integral component of the care we were providing. It's something that we were all engaged in, and not only on our designated behavioral health units. So one step toward integration was in terms of our interview and hiring process. We hadn't always owned that we served a significant behavioral health population. And so I wanted to clearly communicate this in our interview process and ask specific questions about providing care to individuals with behavioral health needs and incorporate this as a factor in our hiring process. We also implemented a focused behavioral health orientation. So all chaplains and CPE students would provide on-call coverage as the only chaplain in the facility, and any chaplain could be called to a behavioral health unit. So this orientation provided some information about accessing the locked units, collaborating with nursing staff, and again emphasized safety. What are steps that support chaplain safety? What are religious items that could pose a potential safety concern? And how do we offer appropriate alternatives that are both safe and address the underlying religious and spiritual needs in an appropriate way? We also identified opportunities to incorporate mental health education within the CPE program we collaborated with at the time, offering education on behavioral health for chaplain students. We found opportunities for students placed at our site to gain experience on behavioral health units, and we did this particularly through students shadowing and co-facilitating groups. Now, before I move on, I want to highlight a few strategies and resources that I think can be helpful to develop competence at this informed level. So in parts 1 and 2 of this series, Kirsten and I have shared a supplemental handout that includes resources around these 4 educational strategies. And these strategies are aimed at developing chaplain knowledge and skill at this informed level. And they're relevant, I think, to every chaplain across all care settings, whether or not we work specifically in mental health. So since we've spoken about these strategies previously in parts 1 and 2, I won't add much more today, but this resource is available as a handout in the chat and along with the recording. So the second level of the empowerment model is the behavioral health practitioner. And this chaplain practitioner level reflects that chaplains need some additional competence when we're interacting with acute mental health needs in a more focused or ongoing way. So this might include working regularly on a behavioral health unit or facility, collaborating with the behavioral health interdisciplinary team, or planning and facilitating groups. So these are just some examples of activities that would require some additional chaplain competence, building on that informed level with this behavioral health practitioner level. In terms of knowledge, this level builds on the basic concepts we saw previously toward a more complete understanding of mental illnesses and their symptoms. So chaplains in mental health settings assess spiritual needs, and we also need to be able to assess what kinds of care are appropriate in a given moment. Mental illness impacts judgment, cognition, perceptions, emotional regulation, and all of these factors are going to be relevant to how we engage and provide spiritual care support. In addition, understanding illnesses and their symptoms also helps us to understand, empathize, and respond in a more non-judgmental way. When we're working with mental health needs in a more focused way, we also need to appreciate the complexity of the interaction between religion and spirituality and health, and how religion and spirituality impact the experience of illness and ways of making meaning. As we saw in part 1, religion and spirituality are often supportive factors, but they can interact with health in ways that are complicated and nuanced, and that's important. It's important for us to understand in terms of how we approach care recipients, how complex and nuanced those interactions can be. Another important area of knowledge is in understanding groups and group process. In mental health treatment, care is often provided in the context of groups and group interaction, and group facilitation may be part of a chaplain's responsibilities in behavioral health. Also, outside of formal groups, in mental health, we're often navigating shared spaces where multiple patients or care recipients are present at the same time, and an understanding of group dynamics is relevant to those interactions as well. One important value at the practitioner level is a patient-centered approach that is inclusive of people of different cultures, beliefs, and abilities. I emphasize this because our chaplaincy approaches often focus on verbal engagement and reflective process. And these require a very high level of cognition that is not always reflected in the people that we care for. In an acute mental health crisis, as in any kind of acute crisis, it can become very difficult to think clearly or process information. We also care for people with different abilities, impacted by different illness symptoms and medications. And so it's important to be patient-centered in how we provide our care, being creative and adaptable to find a way to meet the need to the greatest extent possible, and not waiting or expecting that a care recipient can engage with us in ways that are comfortable or familiar for us. Another core value is taking seriously the spiritual and religious lives of people with mental illness. Especially in the context of serious mental illness, often any expression of spirituality or religion is dismissed as a symptom. So we do have to acknowledge that spirituality can be disrupted or thwarted by mental illness. We don't want to reinforce symptoms or contribute to unhealthy religious or spiritual coping. But we also don't want to dismiss or ignore the spiritual life of any person. So chaplain practitioners bring sensitivity and nuance to this complexity in a way that reflects our professional values, as well as the research evidence that spirituality is an important source of well-being in the context of serious mental illness. The skills at this chaplain practitioner level include providing appropriate spiritual care interventions in response to complex behavioral health symptoms, such as delusions with religious or spiritual content. The first and most basic level at which we can intervene is by listening, seeking to understand, communicating dignity and respect. And from this foundation, we can build rapport, we can explore the feelings, values, and meanings that are being experienced and expressed so that we can affirm and empathize with the person. Another important skill is around group facilitation, which really is a set of skills. One of the skills under this umbrella of group facilitation is the ability to choose group content and materials that are appropriate for the needs of a clinical population and appropriate to the care environment. Effective group facilitation requires maintaining an environment of safety and respect that is supportive for group participants. In a group setting, there will likely be symptoms or behaviors that take place in the group that could be disruptive to the group or other participants. And so a facilitator needs to establish, communicate, and maintain appropriate group norms, and to manage or redirect disruptive or problematic behaviors. Of course, in any group setting, the needs and interests of group members might be in tension or conflict with one another. And so we work to balance the needs of each individual and the group as a whole. Another important group facilitation skill is being able to communicate the goals and purpose of a chaplain-led group and how the group intervention contributes to and supports the overall plan of care and treatment goals. And a final area of competence is collaboration with the interdisciplinary care team. The nature of mental health treatment requires alignment among members of the care team. And so as chaplains, we need to demonstrate that we understand and align with the plan of care. So this includes effective communication with the care team in terms of the information we receive and share, and contributing to the plan of care for those persons receiving our support. So again, we'll come back to this case example and some of the steps we were able to take to develop competence at this practitioner level. As I've mentioned previously, a proportionately smaller percentage of chaplain resources were allocated to behavioral health compared to our patient volumes. So I looked to address how we were deploying chaplains by engaging our spiritual care team in a unit assessment process, and this resulted in some adjustments in how we provided our chaplain coverage. And with this change, I wanted to shift from the model of one behavioral health chaplain working in relative isolation and evolve toward a more team-based approach of providing care. Again, I was aiming for consistency with the standard for how we provided care throughout our hospital. Our spiritual care model was that a primary chaplain was assigned to each unit for consistent presence and support, and additional spiritual care team members offered additional coverage and support so we could consistently address needs in a timely way. And so my goal was to increase the capacity of our chaplain team so that we could also work in behavioral health as a team and better shift our resources across clinical areas based on needs and chaplain availability. This was also important so that the care in behavioral health didn't depend on just one person, but as we experienced time off or turnover, the team still had some capacity to respond to the spiritual care needs that were present in behavioral health. So to implement this team-based approach, I identified chaplains with skill and interest in mental health and worked to develop that competence through peer-to-peer education, support, and shadowing. This educational support was offered informally. A chaplain might shadow groups and then co-facilitate groups before leading groups independently with some ongoing mentorship and support. As an additional benefit, these chaplains developed knowledge and skills that they could use in many other environments, in the emergency room, in a crisis, and all the other situations where we encounter mental health needs. And this also created some opportunities for professional development for our chaplain team members. The team-based approach helped to energize a number of quality improvements. We had more ideas and collaboration. So one change we made was around our group materials. We often used music in our spirituality groups, and we sought out songs in different languages and cultures to more inclusively reflect our patient care population. We adapted group materials to make them as safe as possible, and we also paid careful attention to our written materials. The written materials we used in groups could often pose challenges in terms of patient literacy, eyesight, the ability to focus or concentrate. So we were very conscientious about to have clear formatting, about the amount and size of text on any written materials, and incorporating images along with words. We implemented a shared group calendar to better coordinate how chaplains were providing support on each of our behavioral health units. And this more consistent chaplain presence allowed us to build better rapport with staff, provide more associate care, better communicate information about patients and their needs, and also better educate the interdisciplinary team about chaplains and our interventions. As an example of the proverbial low-hanging fruit, we also took advantage of CPI training, that's crisis prevention and intervention training. And this training was already offered on site on a recurring basis. It was required of all behavioral health staff, but was something that chaplains had not done. So we were able to get all our chaplains who work consistently on behavioral health engaged in this training, and it was something we could do alongside our interdisciplinary colleagues. Now, I know it's not always clear or obvious how we might develop our skills at this practitioner level, and I'll share some thoughts and ideas about how we might build knowledge and skill in this area, emphasizing resources that are accessible in terms of time and cost. So one strategy for education at the practitioner level is building knowledge around the behavioral health sciences. We can seek out education on illnesses, illness symptoms, and different treatment approaches. So one way to develop this knowledge base might be taking a course on abnormal psychology, either at a local institution or through an online platform like Coursera or edX. The Substance Abuse and Mental Health Services Administration offers a wealth of webinars and resources, including for a range of specialty populations that you can find through the practitioner training section of their website. And if you enjoy podcasts, podcasts such as the Psychiatry and Psychotherapy podcast, though there are many others, offer episodes on many different mental health topics and offer another accessible way to build some basic knowledge in this area. Another strategy is to engage writing and research within the fields of psychology and psychiatry on the role of religion and spirituality in mental health. These are very relevant to our work as chaplains, and they are growing areas of research and interest in the mental health field. Finally, to be an effective clinician, knowledge is an important first step, but it's really important that we know how to use and apply that knowledge to develop our clinical skills and gain clinical experience. So I also highlight mentorship and peer support. I know this can be a challenge if we work in isolation or don't have obvious sources of support. But I think as we can be creative and advocate for ourselves and our team members, that we can often find colleagues, both within and outside spiritual care, that we can engage for feedback and support. So the third and final level of this empowerment model is the behavioral health chaplain leader. This level reflects that the work of integrating mental health and spiritual care can require some further skill and competence. And this level builds on the previous two levels, incorporating some additional leadership skills related to education, advocacy, innovation, and research. Knowledge at the leader level includes spiritual care best practices across diverse settings. So we need different strategies and approaches for different clinical populations. And this level of competence reflects a depth of experience and ability to adapt. A key value for the chaplain leader is elevating the quality of our care. This means not only providing the best possible care through our individual clinical encounters, but also through our broader engagement with systems of care and interaction with other care providers. The skills at this leader level build on the group facilitation skills we saw previously and incorporate additional competence in developing and adapting group content and curriculum. So as an example, when I first started facilitating groups in behavioral health, I was fortunate to learn from an experienced chaplain and learn an existing group structure that was well suited and flexible to the clinical needs of that particular environment. And working within this format gave me the opportunity to develop clinical and group facilitation skills. However, when it comes to implementing a new group structure where one may not exist, developing new group curriculum that is responsive to the clinical and developmental needs of the care population, or working with staff who don't have a context to understand what a spirituality group is about, this becomes much more difficult than working within an established group framework. So I'll expand on this a little more through the case example, highlighting some of the unique skills at this behavioral health chaplain leader level, as well as touch on some of the skills related to education. This includes education for chaplains and chaplain students, as well as education for our interdisciplinary colleagues. So coming back to this case example, one opportunity for chaplain leadership was in building connections and relationships with colleagues and leaders in behavioral health. And one of these connections led to an opportunity for us to participate in providing brief education for nursing students. We often had nursing students present on behavioral health, sometimes observing chaplain-led groups, and having a number of students in a group could pose a challenge to the group dynamic, particularly if the students weren't clear on the goals or rationale for the group. So through networking with nursing preceptors, we found an opportunity to share a brief educational session with nursing students, discussing the role of the chaplain in a mental health setting, providing some understanding about the role of spirituality in mental health treatment more generally. And this education helped to mitigate some of the potentially challenging dynamics of having students present in a group and supported the education of our interdisciplinary partners. A second area of focus was related to curriculum development. One challenge we encountered is that the inpatient environment could be unpredictable. It wasn't always possible to anticipate the needs of a particular group on a particular day, and developing a library of resources allowed greater flexibility in responding to the needs and interests of different groups. This was also important in our response to the COVID pandemic, which required us to adapt very quickly in terms of how we provided groups. And we also had some resources that could be shared if a patient was in isolation and not able to participate in the group, that they had some adapted group materials that they could engage with. We also worked to develop a group structure for our pediatric inpatient units. This was a new group in a clinical area without much previous chaplain involvement. And there were a number of clinical and organizational complexities, which made it challenging to find group materials that were functional and effective within the setting. So my colleague Kirsten drew from some of her varied experiences and background to develop a 6-week group series around themes like gratitude and self-compassion. And each group topic was presented in the form of a game and followed by an activity. And this became a much more effective way to engage our pediatric population in spiritual care support. And as an aside, Kirsten will be sharing more about this approach through a workshop this summer at the APC-NACC Joint Conference. Finally, my role did grant some institutional leadership. In part due to being in a Catholic healthcare system, I was often asked to share words of reflection or blessing at different meetings or events. And I used that role to intentionally highlight stories and examples relevant to behavioral health, to celebrate the work of behavioral health staff and leaders, and to connect that work to our sense of mission and identity in ways that I hoped would be supportive for mental health care workers and would counter some of the associative stigma that I observed. So I'll quickly highlight a few opportunities and needs around education at this chaplain leader level. For one, we don't know a lot from the published literature about what chaplains' work in mental health looks like. I think we know that chaplains are working in mental health. We don't know much about what kinds of care chaplains are providing. So one educational opportunity is to describe and share the work that many of us are already doing in mental health. As I've suggested before, learning about the behavioral health sciences is an important first step. However, we also need to integrate that knowledge with our own spiritual care values and areas of expertise. And I think there are opportunities to deepen our integration of both sources of knowledge, both psychosocial theory and the spiritual religious wisdom traditions that we draw from, and thinking and integrating both and how they inform our work. Working in the intersection of religion, spirituality, and mental health, we also see a need for resources that reflect greater cultural and religious diversity. I think this is especially true in light of what we know about the barriers and disparities in access to quality mental health treatment. A final educational opportunity is reflecting on the unique contributions of the chaplain role, especially as we see some greater interest in spiritually and religiously integrated treatment. It invites us to consider what is distinct about spiritual care provided by a chaplain that might not be represented in the way a psychologist or social worker or another professional might respond to the spiritual or religious dimension of care. So before we transition to questions in just a moment, I want to return briefly to where we started with these values of equity, integration, and empowerment. And again, these are not a benchmark to judge or evaluate our care. They are values that we can live into and express through our work and through our interactions. So whatever your role is or whatever setting you work in, my hope is that you might feel empowered to take some small steps to express these values or other important values that you hold and how we respond and provide spiritual care to persons with mental health needs. I also want to share my contact information as well as Kirsten's contact information. We are very happy for you to be in touch with us for continued conversation, questions, or other engagement. So I think now we'll open it up for questions.
Thanks, Rachel. So far, there's no questions in the chat box. But
yeah. Maybe we can give it a minute and see if folks have any questions they want to. Feel free to take those out.
Someone did ask if your slides were available. They can just email me and I can send out the PDF if you're okay with that.
Absolutely.
Can you see David's question?
I see a question. Could I speak to the Joint Commission's expectations? This is unfortunately something I don't know enough to be able to speak to that. Yeah, that's not something I'm familiar with.
Oh, John Wellwood, yeah, he's fantastic. Did you see the comment from Catherine Engel?
Oh, wow. Okay. I think, Andy, you're probably better at navigating this, these questions than I am. So if there's anything I'm missing,
Sure.
please let me know.
Sure. Can you speak to the instances when chaplaincy interventions are not appropriate in mental health, behavioral health?
Instances when chaplaincy interventions are not appropriate. I don't know that I would ever say outright that chaplaincy interventions are not appropriate. Again, I think this is a time we rely on our clinical judgment and our clinical experience, right? Certainly there are interventions that are not appropriate, or ways we might have to adapt the way that we are intervening in order to account for the fact that I think especially that religion and spirituality are not universally positive and supportive. You know, if we see someone is using religion or engaging with their religious or spiritual beliefs in a way that is detrimental to their mental health, we want to be very thoughtful in how we engage with that dynamic.
Linda Joyner asks, what is the best way to learn how to deal with behavioral health patients? Broad.
Yeah, I think I appreciate that question. It's something that we're all encountering. So even if you don't work on a behavioral health unit, you are absolutely, I think every chaplain every day is working with people with mental health needs. I think if you're just getting started, I would refer you to that handout, the resources, the educational strategies that are in that handout, which speak to just gaining some basic mental health literacy. And also, we also really emphasize first-person accounts, which are ways of hearing about, hearing from people with lived experience with mental illness.
Right.
And I think that can build our capacity to empathize and understand where people are coming from. Just like in any sort of situation we might encounter as chaplains, there's not always kind of a right answer. Things are not usually black and white, right or wrong. So I think, you know, I try to highlight a few different educational strategies at each of those levels that I hope will be helpful for folks. I'd also, if you're looking for more context on sort of the individual clinical encounters, part 2 of this series, Kirsten did a really great job giving some examples of that. So I'd refer you back to part 2 if you haven't seen that yet.
Okay. One question came in from Yulia. Our hospital's building a new behavioral health center and is planning to include 1 FTE for a chaplain. What is your suggestion for a search for a chaplain for this position? What would you be looking for, since there is not necessarily a specialized CPE training for mental health chaplaincy? Although, you know, if I could interject, there is, I believe, the CPE program at McLean Hospital in Belmont, Massachusetts, that Angelica Zolfrank is leading. Would have that. Do I have that right, Rachel?
I believe so. Yeah. So yeah, but for the most part, there's not necessarily a clear or obvious pathway for chaplains to become a mental health chaplain or develop this kind of skill and competence. For myself, I can say I learned most of it as I went along, right? Learning about mental health, mental illness, and sort of thinking about how to engage with that in a way that reflects my chaplaincy skills and values and perspectives. I like this question about what to look for. You know, I think I don't know that I have a real clear answer, but I think a lot of the things that chaplains do are really relevant to behavioral health. You know, like we are probably working with groups all the time, right? If you are working with a large family in the context of a death or a traumatic event, you're functionally working with a group, right? A group of people who have different needs, different priorities, different emotions, and sort of navigating how we can best as a chaplain support the needs of each individual and the group as a whole. I think being able to be reflective about the stigma that we hold, the values, the perspectives that we hold. I think, stigma is something I really emphasize all throughout the different levels of the empowerment model. I think that's just, I think something that can create can really be a blind spot for some clinicians, some chaplains, if we haven't really engaged, with those experiences, right? So back in part 1, we said that in the United States, about 50% of us will meet the criteria for a diagnosable mental health condition at some point in our lives. So that means that every one of us, right, has either, if we know one other person, the odds would suggest that we know someone who either has or will have a mental illness at some point. So it's something we all have experiences with, and if we haven't reflected on that, can really pose some challenges. So that's not a very complete answer to that question, but if you are interested in reaching out to me by email, I'd be happy to give that some more thought.
Linda, join ahead and follow up. I deal with a person who has mental health challenges. They often say, you don't know what it is like to be me. They are not receptive to help from a mental health expert and religious leaders. I mean, that's axiomatic,
Absolutely. I don't know what it's like to be anybody else, right? I don't know. What would you like me to know, right? About, or is there anything you'd like me to know about what your experience is like for you? I think a lot of people do have all kinds of baggage around. I mean, baggage maybe is a little too dismissive, but people have a lot of history around religious and spiritual leaders that can lead people to not being very receptive. People have a lot of experiences around mental health professionals, around healthcare in general, right? And all of these can lead to mistrust, right? I think that's my what I might, without knowing more about the specific kind of
just one last a minute. Would you consider a candidate that doesn't have any concrete experience with working in behavioral health, mental health specifically? That's a good question.
I kind of, my instinct is to say no, that I wouldn't exclude somebody with behavioral health, mental health specific experience. Potentially, I think if this is the person who is speaking about a new program, right, or okay, then I think, I think in that instance, you might really want to engage somebody with some more of those skills at the chaplain leader, if at all possible, someone who does have some previous experience, especially since this is a new program in a new institution. That sounds like something that could reflect some of that complexity. If we are, if we have an existing program or a program that's up and running, I think I might tend to look for the openness to learn, the receptivity to learning, rather than kind of the specific knowledge and experience.
And I think that's a good note to end on. Thank you so much, Rach. And
my pleasure.
Emails to you and Kirsten are in the chat. And the resources will be sent out anyways. Anyone who wants the PDFs can email me.
Yeah, and feel free for folks who have additional questions or points for clarification.
If I get anything, I'll pull you in as well. And I encourage people to take a look at the the research network that we have on mental health and chaplaincy, and join that if they don't already belong to one of our research networks. If they do, it's easy to add that to your palette. But thank you so much, Rach. I'll see you soon. Thanks, everybody.
Take care, everybody.